In today's meeting, I'm very happy to introduce Dr. Mbambo, who's one of our interns here at the Family Medicine Department, and herself and Dr. Yusimi has done a lot of effort to put together this presentation for us today. I'm going to hand over to her. Thank you very much and welcome.
Thank you, Dr. Miller. Good morning, everybody. I'm Dr. Mbambo. All right, so let's get stuck into the presentation. So we have a patient VN, a 48-year-old female, referred from her local clinic to CMH GOPD for colposcopy and biopsy of a low-grade cervical intraepithelial lesion, or ulcer, found on Pap smear. So on presentation, the patient is asked about her HIV status, of which she was unsure, but she gave consent for testing. An HIV ELISA was done, as well as a cone biopsy, and the patient was given a follow-up date in 1 month. So on review the following month, the patient was informed that she's HIV positive, but that the cervical lesion was adequately excised. Therefore, she should repeat her Pap smear in 6 months at her local clinic. Baseline blood investigations were done before her referral to the CMH Wellness Unit. So on presentation at the Wellness Unit, the baseline clinical evaluation showed a negative screen for STDs, mental health conditions, major non-communicable diseases, and TB. The nutritional assessment was adequate with a BMI of 19.17. On past medical history, she had a previous pulmonary TB in 2013 and completed 6 months of treatment. She had no prior surgical history, and she was of sober habits. So on sexual history, she described having sexual activity with one partner with irregular condom use. And on obstetric history, she described her last normal menstrual period as being 3 years ago, and she was postmenopausal. But she's a Grav4 para-3 with the previous first trimester miscarriage. All her previous pregnancies were NVDs with no complications. On physical examination, her vitals were stable, she was apyrexial, and her urine dipstick was normal. On general examination, she was a well-looking lady. She wasn't jaundiced, not pale, not cyanotic or clubbed. She wasn't edematous. There were no palpable lymph nodes, and she wasn't dehydrated, and there were no visible skin lesions. However, on examination of the dentition, on oral examination, there was a purple nodular enlargement on the hard palate and gingival region. The rest of the systems were unremarkable. Her baseline blood results were as follows. She had a CD4 of 37, her serum CLAT was negative, her creatinine was 76 with an eGFR of 124, her hepatitis B surface antigen was negative, and she had a normocytic anemia of chronic disease with a hemoglobin of 10.1. And this was the lesion that was visible on the hard palate. So now you sit there and wonder, okay, now what? That brings us to the topic of our discussion today, HIV and oral lesions. A basic overview of what we're going to discuss today is we're going to look at the anatomy, the functions of the oral cavity, how to examine the oral cavity, what's the significance of HIV and oral lesions, how do we classify them, what lesion types are there and what are their frequency, as well as oral conditions and their management. So a brief overview of the anatomy. You get going from the top down, you get your lips, your gingiva or your gums, your teeth, your hard palate, your soft palate. You have your uvula and tonsillar pillars. You have your buccal mucosa and you have the floor of the mouth. And then you have your tongue with the dorsal aspect and lateral aspect. What are the general functions of the oral cavity? The oral cavity is very useful for digestion as it is involved in the initial processing of food. It's also useful for phonation, because that's how we manipulate sounds to produce speech. It's also useful for respiration, as it is an inlet to the upper respiratory tract. And of course, the other use is for aesthetic purposes. So, oral lesion history essentials. What do you need to find out from the patient? So you need to find out about the location of the lesion or lesions. What's the color and quality of the lesion? Is it red, white, erosive? Is it bullous? Is it macular or papular, and so forth? How long has the lesion been there? And has it changed recently? Has it changed in color? Has it enlarged? What are the associated local symptoms? Is there any pain, bleeding, or discharge? Does the patient have any systemic signs and symptoms, such as fever, unintentional weight loss, rash, or arthralgias? What medications is the patient on, and has there been any change in medications? And importantly, has the patient been using topical oral medications? Does the patient have tobacco use or alcohol consumption? Is there any medical history, because some medical conditions are associated with certain oral lesions? And don't forget to ask about the dental history. Does the patient use any dentures? Has the patient had any previous dental surgeries? And a brief overview of how to examine the oral cavity. I'll mainly focus on the intraoral examination, because there's also extraoral involving the perioral regions and the cervical or regional lymphadenopathy. So in the mouth, you would like to retract the lips. You need some artificial light so you can see adequately and visualize the oral cavity. Have a look at your buccal mucosa, as well as the Stensen's duct, which is the opening of each salivary duct into the mouth. Look at your gums and teeth, the floor of the mouth, and a place called Coffin's Corner, which is the posterior corner of the floor of the mouth, and it is mainly associated with squamous carcinoma lesions. Look at the tongue, the different aspects of the tongue. Look at the hard palate, and then you palpate the floor of the mouth and the submandibular gland. And then you also look at your tonsils and your uvula, your tongue base, and your posterior pharyngeal wall. And then this is just a visual representation of how you would examine these different aspects. So before we move on to the abnormal oral lesions, what are the normal variants of the oral mucosa? You could have a condition called leukodema, which is a benign change in mucosa. It's usually asymptomatic, bilateral, and it presents as a gray-white, semi-transparent change in the mucosa due to accumulation of fluid in the epithelial cells of the mucosa. It usually disappears with stretching of the mucosa. Another condition is called Fordyce granules or Fordyce spots, which is basically ectopic sebaceous glands that are found in the mouth. They're usually white or yellow, around 1 to 2 millimeter papules, and they're symmetrical on the buccal mucosa and vermilion of the lips. There's another condition called physiologic oral pigmentation, which is usually seen in people with darker skin types. It's the result of increased melanocyte activity and melanin production, hence the brown-gray band that you see, which can be attached to the gingiva bilaterally, but it may also be seen in the hard palate, the floor of the mouth, or the buccal mucosa. So going on to the significance of this discussion. According to a retrospective cross-sectional study done here in South Africa in Galifong Hospital, published in the South African Dental Journal, they did find that there's a relationship between the incidence of oral lesions in HIV and that a lower CD4 count, typically less than 200, is related with an increased incidence of oral lesions, and that the prevalence of HIV-associated lesions in patients receiving highly active antiretroviral therapy is markedly reduced compared to those not on treatment. And they describe this order of frequency of oral lesions. As you can see from this table, oral candidiasis marks among the top most frequent lesions in HIV. According to another study done in Lebanon, in Africa, oral lesions are common findings in HIV-infected patients. As the CD4 count decreases, the appearance and severity of oral lesions also increases, and that a diagnosis of oral lesions may point you to a positive HIV status in a patient who was previously unknown, or it may indicate progression of HIV disease. Another systematic review done in 2000, a couple of years ago, however, in Birmingham, they also agreed with the above findings with regards to the importance of oral lesions in HIV infection. And this is just an overview of the WHO clinical staging. And it is important to note that oral lesions are quite frequent findings in the different clinical stages, and they may be pathognomic of a clinical stage should you find them. How do we classify oral lesions? We can classify them etiologically, according to what's the cause of the oral lesion. Is it fungal? Is it viral? Is it bacterial? Is it neoplastic? Or is it due to autoimmune diseases? Another classification that was done with the European Community Clearinghouse together with the WHO. They classify these lesions according to group 1, 2, and 3, based on the whether lesions were strongly associated with HIV infection, those less commonly associated with HIV infection, and those lesions that are seen in HIV infection. And these are the different groups. Group 1 being those lesions strongly associated with HIV. And as you can see, oral candidiasis, hairy leukoplakia, Kaposi sarcoma, non-Hodgkin's lymphoma, and the periodontal diseases among those lesions strongly associated with HIV. So let's move on to the different classifications. In terms of fungal oral lesions, oral candidiasis is among the most common. It is caused by the Candida albicans species most commonly, but it may be caused by other Candida species. It has a prevalence of 33 to 50%, and it's an indicator of immune suppression. It's commonly seen in patients with a CD4 of less than 200, but it may occur earlier in the course of disease. Its clinical manifestations can be subdivided into pseudomembranous, otherwise known as thrush, erythematous or atrophic, angular cheilitis, or chronic hypertrophic candidiasis. Pseudomembranous candidiasis counts among the most common oral candidiasis. It presents as these creamy white plaques involving the oral mucosa. It may be on the tongue or the oropharynx. These lesions are typically easily scraped off with the tongue depressor or gauze. They are usually painless. And if the patient complains of adenophagia, then it's likely that esophageal involvement is present. And they may also present with the burning sensation or altered taste. And these are the typical lesions that are seen in pseudomembranous oral candidiasis. And this actually reminds me of common foods that we see on a daily basis, such as cottage cheese or scrambled eggs or Mars and granola. So, in terms of erythematous candidiasis, these conditions include denture stomatitis, chronic atrophic candidiasis, and angular cheilitis. And they usually present as flat red patches, commonly on the hard palate and surface of the tongue. They may have superimposed pseudomembranous candidiasis, and they may also present with a burning sensation or altered taste. And these are the typical lesions that are seen. And then angular cheilitis is erythema and splitting of the lateral commissures, otherwise known as the corners of the mouth. They may be unilateral or bilateral, and they're usually very painful. And then chronic hypertrophic candidiasis are these white or red speckled lesions that may also occur, at the lateral commissures of the mouth. They commonly occur buccally. And the important thing about these ones is that they are adherent, meaning that they're not easily scraped off with the tongue depressor. So how do we diagnose these lesions? Typically, it's on a clinical basis based on the clinical findings, and we give an empiric trial of antifungals and assess response. However, if you want definitive diagnosis, then you do a direct smear with potassium hydroxide wet mount, and you do a gram stain where you'd visualize yeast cells. And then fungal cultures are not typically done, but they're for more non-responders to first-line treatment or suspected resistance. How do we manage these? Oral hygiene plays an important role. And then we can also give topical polyene antimycotics. According to the EML, this is if there's no esophageal involvement. We generally give nystatin suspension of 1 ml orally 6 hourly after each meal or feed for 7 days. How does one do this? If it's an adult, you just ask them to keep the suspension, the 1 ml in the mouth for as long as they can before swallowing. In the younger child, you may ask them to swirl it around their mouth before swallowing. And in a baby, you may ask the mom to put the 1 ml in the mouth and then with a clean finger, swirl it around. Treatments are imidazoles and triazoles. That's if there's esophageal involvement, which may be typified by painful lesions with adenophagia. And for these, we give fluconazole 200 milligrams orally, or if the patient cannot tolerate oral treatment, it's IVI 24 hourly for 14 days. If the patient relapses, we give a 4-week course. Other options of antifungals can be itraconazole. Moving on to the viral lesions, we have oral hairy leukoplakia. This occurs in about 20% of individuals with HIV, typically with moderate to advanced immune suppression, stages 3 and 4, and with those with the lower CD4 counts, approximately 200 to 300 or less. It usually signifies a worsening condition or decline in effectiveness of the antiretroviral therapy. Prevalence is decreased with effective antiretroviral therapy, and the organism responsible is the Epstein-Barr virus. However, the mechanism is unclear. How does it present? It presents as these white, raised, irregular, hairy, feathery type lesions that are corrugated in nature with ridges and grooves, much like corrugated iron. It doesn't have any surrounding erythema or edema. They're typically found on the lateral aspect of the tongue, and less commonly on the buccal mucosa and oropharynx. These lesions are adherent. They are not easily scraped off. Patients are usually asymptomatic, and if they are symptomatic, they can experience glossidynia, dysesthesia, and altered taste. They may be unilateral or bilateral, and these are the typical lesions that you would find. How do we diagnose these? Again, typically based on the clinical picture. For definitive management, if you're unsure about the diagnosis or if you think it might be a cancer, you take a biopsy for histology. Typical findings on histology are cellular nuclear changes such as acanthosis, type A inclusions, and epithelial hyperplasia. And you may also demonstrate replicating Epstein-Barr virus in the histological sample, although this is rarely done. You may also take a specimen for cytology for Epstein-Barr virus PCR. How do we manage these? These lesions typically resolve spontaneously, especially with giving antiretroviral therapy. When would you treat them? If the patient is symptomatic, or if their cosmesis is affected, or their quality of life. Treatment options include systemic antiviral therapy, such as high-dose acyclovir of 800 milligrams orally 5 times a day for 7 to 14 days. And you also have other options of antivirals. Or you can give them topical therapy in the form of podophyllin resin, which is basically cytotoxic. And you can get formulations which combine the podophyllin resin with acyclovir cream, which you can apply topically 12 hourly for 3 days. You also have the option of using topical retinoic acid. Lesions, however, often recur several weeks after cessation of therapy. Moving on to herpes simplex virus. Herpes is a Greek word meaning to creep and crawl, which describes the spreading nature of the lesions. You get type 1 and type 2. HSV type 1 being more orofacial disease transmitted via saliva, and HSV2 being more genital disease transmitted via sexual activity or vertical transmission. However, they can overlap. Cellular immunity plays an important defense against HSV, and impaired T cell function, as seen in AIDS, results in dissemination. So the clinical cause depends on the age and immune status of the patients, the anatomic involvement, and the antigenic virus type. Primary infection results in a more pronounced immune response. You'll see more systemic signs and a longer duration of symptoms and a higher complication rate. And it's important to note that in immunocompromised patients, the presentation is generally more severe with prolonged and widespread infection, and there's an increased likelihood of recurrence as opposed to the immunocompetent patients. It affects in generally 2 ways, the oral lesion manifestation, that is. So they may present as acute herpetic gingival stomatitis, which can be primary or recurrent infection. Outside of the HIV population, it generally occurs in children 6 months to 5 years. It's of acute onset with an incubation period of 3 to 6 days. General symptoms include fever, malaise, and aphasia. Primary infection classically appears as these small vesicles affecting the oral mucosal surface, the tongue, the hot palate, the gingiva, and the lips. These vesicles tend to rupture, and when they rupture, they form these circular painful ulcers, which can coalesce or join together to form larger lesions. And you may also have a gingivitis with a very red and angry gingiva. You may also have associated tender regional lymphadenopathy, such as usually cervical lymphadenopathy. You may also have perioral skin involvement due to contaminated saliva. The course of the disease is usually self-limiting. Symptoms subside by 1 to 2 weeks. However, viral shedding may continue for 3 weeks and even longer. And these are the typical lesions that you see. the vesicles on the far left, and your ulcers more on the top right. This reminds me of that angry emoji where you have this vesicle that's red and then it ruptures and then it coalesces to form this ulcer. Another presentation is the acute herpetic pharyngeal tonsillitis, which occurs more frequently in adults. General symptoms in this case are again fever, malaise, headache, sore throat. These vesicles rupture and they form ulcers with exudates in your tonsils and your pharynx. HSV2 may present similarly if associated with orogenital contact or concurrent orogenital herpes. The secondary infection is reactivation of the virus. After the primary infection, the HSV virus, type 1, goes and lies in the trigeminal ganglia, and then type 2 goes to your sacral ganglia. And then secondary infection results in more widespread mucocutaneous disease. Again, in the HIV-infected population, reactivation presents as shallow ulcers that are more widespread. They affect the buccal mucosa, the tongue, and the lips, and they may present as crusting and bleeding, which is similar to erythema multiforme. How do we diagnose this? Again, typical presentation. However, if you want a more definitive diagnosis, you would do cytology and direct immunofluorescence, as well as microscopy and PCR. In terms of management, general measures are important, such as mouth hygiene. You ask the patient to rinse the mouth with homemade salt mouthwash, which is half a medicine measure of salt with a glass of lukewarm water. The patient needs to maintain hydration and also avoid acidic drinks such as orange juice or soft drinks, as these tend to exacerbate pain. You may also use petroleum jelly for lesions around the lips. In terms of medical management, analgesia is paramount in the form of paracetamol, as well as local anesthetic. You can give tetracaine 0.5% topically 6 hourly on the affected area intraorally. In terms of antivirals, what are the indications for these? It's generally in children with extensive herpes if the treatment can be started within 72 hours of the onset of symptoms, and in HIV-infected patients with oral facial HSV infection. We tend to use a cycle of 400 milligrams orally 8 hourly for 7 days. In children, it's 250 milligrams. And you also have your other options of antivirals. If there's no improvement after 1 week, or the patient's very dehydrated and clinically unwell, you need to refer this patient. Moving on to herpes zoster. So this is a viral infection resulting from the reactivation of the varicella zoster virus, otherwise known as chickenpox. It mainly causes skin lesions, which are painful and self-limiting. However, it can cause intraoral manifestations, especially if it's involving the trigeminal ganglia in the Ramsay-Hunt syndrome with cutaneous, intraoral, and otic vesicles. It can affect the maxillary branch, and then in that case present with upper teeth, severe toothache, infected tonsils. It can be at the roof of the mouth, or it can be on the oral mucous membranes. It can present in 3 ways. In this pre-eruptive phase, also known as preherpetic neuralgia, it may present as altered sensation. Patient may feel pain, itching, or paresthesia along the dermatomes, lasting about 1 to 10 days. It may present with malaise, myalgia, photophobia, headache, and fever. Then you get the acute eruptive phase, where you get the patchy erythema with induration, importantly in the dermatomal distribution of the maxillary and mandibular branches. These vesicles tend to be grouped on a base of erythema. So these vesicles can also rupture and lead to ulceration and may be associated with regional lymphadenopathy. And then you get the chronic phase, the persistent herpetic neuralgia. And they generally present in this way. As you can see, they're generally grouped in the dermatomal distribution of the maxillary and mandibular branches. One way you can remember this is birds of a feather flock together, describing how they can be grouped in the dermatomal distribution. How do we manage these? Analgesia is important because they tend to be very painful. You do this in a stepwise approach where you start with your paracetamol that you can give 1 gram per hour 6 hourly. If that's inadequate, you can add tramadol. And if that's inadequate, you can upscale to amitriptyline. In terms of antivirals, you can give a cyclival high dose, 800 milligrams 5 times a day. How you give the 5 times a day, you give it 4 hourly, but you just omit the midnight dose. So we're talking about human papillomavirus, that it has different genotypes that have a propensity to infect different body sites. Cutaneously, it's mainly HPV type 1, 2, and 4. And in terms of the anogenital epithelium, over 40 mucosal HPV types can infect the genital tract. And they can be further subdivided into genital warts, which is mainly HPV type 6 and 11, squamous intraepithelial lesions. There are 15 HPV types described, but type 16 is the most commonly associated with cancer. And then it may also affect other mucosal surfaces. And HPV type 16 in particular can infect the oral mucosa and is associated with squamous cell carcinoma of the oral cavity. In terms of oropharyngeal infection, it typically occurs more in males than females, and there's a higher risk in men who have sex with men. And according to the NACORD study, an analysis of 17 prospective studies between 1996 and 2009, HPV-related and unrelated head and neck squamous cell carcinomas are elevated in patients with HIV, likely due to immunosuppression. The risk of oral HPV increases even with effective ART in patients with HIV, according to UpToDate. Studies, however, are conflicting with regards to the role that ART plays and the effect on HPV risk. How does it present? It presents as these cauliflower-like spiked raised lesions that are white, can be red, or normal mucosa-like. The regions involved are the base of the tongue, the tonsils, the lips, and the gingiva. And benign versus malignant lesions may be difficult to assess clinically. Cauliflowers. Whenever you see them, think of HPV. In terms of diagnosis, they're typically diagnosed clinically on the typical appearance. However, again, definitive management, you may want to do a biopsy and send for histopathology if you think there may be an associated risk of squamous cell carcinoma. How do we manage these? There's no clear standard treatment, and there's a high recurrence risk rates. However, treatment options include cryotherapy with liquid nitrogen, laser therapy, and surgical excision of local lesions. A brief note on Aphthous ulcers. These are painful shallow ulcers in the mouth. In HIV-infected individuals, they are more severe and increased in number, frequency, pain, and duration. Risk factors may be nutritional deficiencies. They may be due to a side effect to certain drugs, such as methotrexate, and they may be found in other conditions, such as inflammatory bowel disease, systemic lupus erythematosus, and so forth. They're classified as minor if they are less than 1 centimeter, and these usually heal within 10 days. They are major if they are more than 1 centimeter. They're usually very painful, deep, and persist, and they usually indicate advanced HIV infection. How do we manage these? Minor lesions are managed with analgesia, with either paracetamol or the tetracaine local anesthetic. You provide nutritional support if there are any nutritional deficiencies. And in major ulcers, these are usually referred for diagnostic evaluation, as well as non-healing ulcers within 10 days. Recurrent ulcer treatment options include topical steroid agents, and there was a mention of thalidomide. But if you recall, in one of the studies that were done, that thalidomide has congenital birth defects as a side effect, and use of thalidomide is sometimes questionable, but it is an option. And these are the typical presentations of Aphthous ulcers. Moving on to the neoplastic conditions, Kaposi sarcoma. This is a malignancy of lymphatic endothelial tissue, so it's a vascular tumor, caused by the human herpes virus 8. It's an AIDS-defining condition, WHO stage 4. It's the most prevalent oral neoplasm in the HIV-infected. About 22% of KS lesions are intraoral, 45% involve the skin and oral, and the oral cavity is the first site of involvement in about 60%. It can also affect other sites, such as the lymph nodes and the viscera, mainly the GIT and the lungs. Intraorally, the most common sites of involvement in descending order of frequency is the palate and the gingival tissue. It presents as an erythematous, depending on the scale of red it is. It may be light or dark red. It may sometimes be blue, purple, or unpigmented. It may be macular or papillonodular, and it can sometimes also be ulcerated. It may be multicentric or symmetrical, and the site of the lesions can predict whether it's a primary lesion or secondary lesion. And usually, palatal lesions indicate that there's also associated visceral involvement. And this is the general presentation of Kaposi sarcoma lesions already. This also reminds me of livers. So whenever you see livers, think of Kaposi sarcoma. How do we diagnose this? Again, it's typically on the typical appearance of lesions, also in advanced HIV disease. For a definitive diagnosis, you do histology if the diagnosis is maybe in doubt. On histology, you find neovascularization with aberrant proliferation of small vessels, atypical spindle-shaped cells with leukocyte infiltration, and macrophages that are filled with hemosiderin as depicted below. How do we manage these? So what's the indications for management? It's to control the spread for palliative reasons, for aesthetic reasons, for pain, and for if the patient has functional impairment. Treatment options, you should give antiretroviral therapy and protraumatism prophylaxis, because remember we said it's AIDS defining, WHO stage 4. And these lesions often regress with antiretroviral therapy alone. And if there's no improvement or there's severe initial manifestations, then we refer for additional therapy, such as local therapy in the form of radiation. You can do external beam radiotherapy or brachytherapy. You can also have intralesional chemotherapy, such as vinblastine, if you have that available. You can also use topical therapy, and you can locally excise lesions that are small and discrete. For systemic therapy, it's for those with poor prognostic factors, such as more than 25 skin lesions, if the disease is rapidly progressive, if there's visceral involvement, or if there's extensive edema, as lymphedema is a common complication, and if there are constitutional symptoms. And systemic therapies include liposomal anthracycline, such as doxorubicin, vincristine, and bleomycin. The other neoplastic condition that can occur is non-Hodgkin's lymphoma. It's the second most common malignancy in HIV disease, and of the oral cavity, 3% are malignant lymphomas. So they generally occur outside of the lymph nodes, and the clinical picture, it typically involves the fauces and gingiva, and may also involve the tongue. They're typically rapidly enlarging masses with bone destruction and can be multifocal. However, they can be mistaken for Kaposi sarcoma if they are slow growing and they have a vascular purple type appearance. They may also be mistaken for dental sepsis or atypical ulceration. Diagnosis is mainly histological, where you find B-cell prominence and these Reed-Sternberg cells as depicted below. And you may also have polymorphic inflammatory background and eosinophils. Management is generally giving antiretroviral therapy and discussing with the oncology unit. Moving on to the periodontal diseases. So periodontal diseases are diseases affecting the supporting structures of the teeth. This is the gingiva, the periodontal ligament roots, the root cementum, and the alveolar bone as depicted below. Many conditions affect these tissues, and they are mainly as manifestations of systemic diseases. 5 types are specifically associated in patients with HIV. These are linear gingival erythema, acute necrotizing ulcerative gingivitis, acute necrotizing ulcerative periodontitis, acute necrotizing stomatitis, and chronic adult periodontitis. So, linear gingival erythema. It's more of a description than a diagnosis. The mechanism is poorly understood. However, it presents as broad, about 2 to 3 millimeter red bands along the margin of the gingival tissue. It may also be diffuse petechial-like lesions on the attached gingiva and oral mucosa. It also has a relationship with oral candidiasis and the use of antifungals, as well as increasing incidence of LGE with lower CD4 counts. The next condition is an acute necrotizing ulcerative gingivitis. So this is usually due to infection with a fusosporoketal organism, such as Treponema vincenti and Fusobacterium nucleatum. There are also other associated organisms. So this one causes a very painful necrotic sloughing ulcer at the tip of the interdental papillae. It spreads along the marginal gingiva, causing widespread soft tissue destruction. Kind of sounds like a necrotizing fasciitis. It also has a foul smelling, you can also have foul smelling breath due to the necrosis. How do we treat these? You give analgesia because they're very painful. You improve oral hygiene. You provide the patient with chlorhexidine 0.2% mouthwash. And you can also give metronidazole for 400 milligrams orally for 5 days. And you also refer to a dentist for local debridement of necrotic tissue. That's generally how it presents. Moving on to acute necrotizing ulcerative periodontitis. So this is a deep-seated and even more chronic form of ANUG. It's the destruction of the periodontal ligament and loss of alveolar bone, and it indicates even greater immunosuppression. Treatment for this usually requires specialist dental treatment for root surface debridement under local anesthetic and also the use of metronidazole. And even a worse progression of ANUP, the acute necrotizing stomatitis. So this is an ulcerative lesion of more than 1 centimeter beyond the gingival margin. It has a typically aggressive behavior with destruction of the underlying bone, loss of the tooth. It can result in an oronasal fistula formation as well. Treatment in this case, if the patient is well enough for a general anesthetic, is surgical management, which requires broad excision of the involved necrotic bone, which is usually the maxilla. If the patient is a poor general anesthetic candidate, then would provide conservative management with analgesia, metronidazole, and oral hygiene. The chronic adult periodontitis is a progressive gingivitis to the point where the underlying bone is eroded. It's characterized by loose teeth, and the treatment as per EML guidelines is oral hygiene, and medication-wise, you give analgesia with paracetamol and provide chlorhexidine mouthwash, and then you refer to a dentist. And briefly, a note on HIV-associated salivary gland disease. So it occurs most commonly in HIV-infected children, and it's quite rare in adults, the pathogenesis of which is uncertain. However, the most common manifestations are a diffuse enlargement of the major salivary glands and xerostomia. So in the diffuse enlargement of major salivary glands, it's mainly the parotid gland that's involved. The swelling is non-neoplastic. It's more of a cystic type, fluctuant, enlarged salivary gland, and then with lymphoid infiltration. It's a diffuse infiltrative lymphocytosis syndrome, which is infiltration with CD8 plus T cells. And interestingly, with DILS, it may be, in the presence of DILS, may be a favorable prognostic mark of HIV disease and may indicate a slower disease progression of HIV due to the presence of CD8 cells, which are cytotoxic to the HIV virion. So enlargement of the gland is independent of the HIV stage or degree of immunodeficiency. In xerostomia, it basically means a dry mouth, and it's secondary to HIV affecting the salivary glands and thus decreasing saliva production. It can be due to drug side effects such as with tedanosine, Indinova, AZT, antihistamines, anxiolytics, and tricyclic antidepressants, to name a few. Management mainly consists of informing the patient to maintain hydration to prevent susceptibility to tooth decay or oral candidiasis. So in conclusion, examination of the oral cavity is vital and should be performed more regularly to pick up lesions at an early stage. Some oral lesions are found in specific WHO stages of HIV and may indicate treatment efficacy or disease progression. The introduction of highly active antiretroviral therapy has greatly reduced the incidence of oral lesions in HIV. Therefore, treatment adherence is vital and should be emphasized. Common things occur commonly, so be aware of the common oral lesions found in HIV and how to differentiate them and their respective management. And if in doubt, discuss and refer appropriately for further investigation or management. These are my references. Thank you.
Thank you very much, Doc, for an excellent presentation. I think that is one for the books that we'll be using again and again and again, and very thoroughly and very well prepared. Just for those of you that were wondering, our patient at the beginning had Kaposi sarcoma, so those of you who were in suspense and had not managed to figure that out. I'm now going to open the floor for discussion. I'm Dr. Madeleine Muller. I'll just be chairing, and we'll start off here, and I'm going to ask Dr. Yusimi is just going to move to the hot seat, and I'm just going to move the microphone closer.
Okay. Thank you very much for the presentation. I just want to make a comment about other conditions that sometimes we see in our setting. And one of these one is the cytomegalovirus infection that usually is characterized by necrotic ulcer with a white halo, and also the histoplasmosis that also present with ulcerative lesion. And both conditions, usually the oral manifestations are part of the disseminating form of the disease. The other thing, we cannot forget about the oral tuberculosis that count for the 5% of the different type of TB, and the patient present with a ulcerative lesion. At the beginning is painless, and later on with the progression of the disease could be painful and associated with odynophagia, halitosis, dysphonia, and sometimes also excessive salivation. And in the oral TB, the most common structure in the oral cavity that is affected is the tongue, mainly in the lateral aspect. And most important, the drug eruptions. Remember that our ARV population take a lot of medication that can give you Steven Johnson or toxic epidermal necrolysis. So we have in all times nevirapine, and we're still providing the Favirenz for our patients, the Bactrim. If the patient has another condition associated like epilepsy, we provide lamotrigine, carbamazepine, and all of this one can cause rashes. And the mucosal involvement in this type of conditions is about 90%. So I just want to finish my comment as a gentle reminder that remember, it doesn't matter the type of program that we are running. Make a habit to offer the screening for HIV to all of our patients. It's the only way that we can detect the HIV in early stage and prevent all of the type of this complication by doing the proper screening, that is the rapid test, not anymore the ELISA that we continue seeing every time that we present a case. And the second thing, once that the patient has been diagnosed, please check the oral cavity.
Thank you very much. Is there anybody else in the room here? If at home you would like to ask a question or make a comment, please either put your hand up or you can also put questions in the chat. So, okay, Dr. Kamle is coming to the hot seat.
A very quick one. Good morning, everyone. Thank you so much for attending. What an excellent presentation. Just a practical thing. Sometimes when someone's there in like respiratory distress, they'll have an oxygen mask on, and you know, you're so worried about SAT and respiratory kind of side of things, you forget to look in the mouth. And I think especially coming out of the COVID era, you know, we also had lots of people with face masks on. So it just kind of really helps you from the get-go about where you're lying with a potential clinical reasoning for the CD4 count. So it's just a practical aspect. I think we've all been caught out before where you present, then later on the patient's not in respiratory distress anymore and you find your KS later on. So just a practical one.
Oh, thank you very much. With people no longer wearing masks, we no longer have an excuse to not look in mouths. I think we've all gotten into the very bad habit of forgetting to look in the mouth. So always remember to check. I see there's no hands up on my chat at the moment, and there's no particular. There's just a comment here from Sister Mona, and she's talked about the fact that one must screen for mental health conditions in all patients presenting to our healthcare facilities, amongst other things. So always looking at the broader picture, not just the condition in front of you. Is there any last comments from here? Dr. Adene is just coming forward. Our HOD.
Thanks for the presentation. It's a very excellently prepared. Just one or two comments on the practical aspects, especially around oral ulcers. I think the point of examining the mouth of patients during consultation should be an habit for every clinician. And a lot of the conditions you've actually highlighted are the things to look for in these patients. And the presentation has actually helped in terms of improving diagnosis in some of the among our clinicians. For non-healing ulcers, especially if you have given steroids, either in form of topical, which is actually what is recommended, especially for minor Aphthous ulcers, that's usually less than 1 centimeter. Those patients may need to be sent across for biopsy. And specifically, we had a case of histoplasmosis, a non-healing ulcer, more like a pontic, like as if you punched out something in the posterior portion of the tongue. And the patient got several courses of treatment without any improvement. And only biopsy actually confirmed histoplasmosis after several weeks of delay in terms of confirming the diagnosis. And our inhaler, cortical, any of the beclomethasone or budesonide inhaler actually can be prescribed for treating Aphthous ulcer. And actually the focus is for it to go straight into the site, and that becomes very practical. But the other thing is we need to be conversant with the WHO recommendations in terms of taking sexual history. It's a common thing I always want to drill our students about. But as clinicians as well, we need to be comfortable to ask questions around partners, but more importantly, the practice. Because a number of conditions we typically used to think Herpes simplex type 2 will be genital herpes. But again, once there's oral genital contact, then Herpes simplex 2 equally gets transmitted, and lesions in the mouth can be due to Herpes simplex 2. And not just only that, painless ulcers around the tongue could just be syphilitic cancer, point of entry of syphilis. And of course, exudative effusion in the oropharyngeal area could just be gonorrhea. So please, it's important for us to be comfortable as clinicians to engage and ask simple questions around what does sex mean to you? What do you really do so that you can have an idea and improve and have an open mind in terms of the options or the hypothesis or differentials we've got in terms of for our patients. But again, it would be nice to get comments from the districts in terms of the school-led program around HPV vaccination. We could talk about it in our meetings here, but we don't really have an idea as to the uptake of the vaccination in the various schools. I will appreciate an input from the team from the districts on what is the trend in terms of the uptake around the HPV vaccination for the schoolgirls. Thank you.
Yes, is there anybody from the district who would like to unmute and answer that question from Dr. Adene about HPV uptake in terms of our vaccination program at the moment in the district? I know COVID interrupted a lot of these programs. I see we've got a great 56 people attending.
Hi, Madeleine. It's Dr. Jaka here.
Hi, Doc. Yes, thank you. Please go ahead.
Can you take this as homework and say maybe next week or another week we will get somebody from the district just to come and brief us on this? I think it's an important question that should be answered with statistics and numbers and whatever they are observing. So I will ask the program manager responsible to come and give us a report sometime. I will indicate when she's available on the WhatsApp group. Thank you very much.
That's an excellent idea. Thank you very much, Dr. J. I appreciate it. Is there any last questions? Yes, Dr. Carl is one of our family physicians. I'm going to hand over to him.
Yeah, thank you, Dr.